Welcome to 12 Lead Part 3, where I'm going to talk about where on the 12 lead we look for the evidence that we need to identify a STEMI and what that tells us about the regions of the heart that are affected. To start with, quick review of limb leads and other leads. We have our limb leads, which are created with a positive electrode, negative electrode, with three or four electrodes on a patient. We can get a variety of views, and these are being viewed from a vertical plane. Now, make sure you're not confused by that, because a vertical plane is in reference to standard anatomical reference, as if a patient were standing up. Our patients are usually lying down when we're doing a 12 lead, but we still refer to that cross section as if you cut the body in half with down the center with a front and a back side. That would be that vertical plane. And these are lead 1 is viewing electricity that moves on that plane from the right arm towards the left arm. Lead 2 is the one we use for most of our rhythm identification because it aligns nicely then that most electricity in a heart should be moving from the right shoulder towards the left leg, essentially. And that's why we typically have a nice positive deflection and can see all the waveforms in lead 2. Lead 3 is viewing the electricity as it moves from the left arm to the right leg. Again, just a different view of the heart, all from that one plane. Augmented limb leads are similar, but they use some machine magic. And what I mean by that is they have a positive electrode that is the electrode that's attached to the patient, and then the machine calculates a negative reference point somewhere in between. And so what it gives us, again, in that vertical plane, but it gives us a view of how much electricity is moving towards the right arm, how much electricity is moving towards the left arm, and how much electricity is moving towards the feet. That gives us 3 more leads just from those 4 limb electrodes. Gives us 3 more views that can help complete the picture. When we move to the chest leads or precordial leads, and those names are used interchangeably, or even just V leads, V1 through 6 are those leads, and this is now in a horizontal plane. Those electrodes obviously are wrapped around the chest in a horizontal pattern, and we're taking a view that is 90 degrees, that's perpendicular to the limb leads and the augmented leads, which provides a nice balance and a good, fairly complete picture of the heart. Now, this is a standard layout that you will see on a 12-lead printout. Well, I have this color-coded to help, and so the 2, 3, and AVF, that little L-shaped set of blocks down in the bottom left, are all looking at the inferior portion of the heart. V1 and V2 are looking at the septum. V3 and V4 are looking at the anterior portion of the heart. And all the rest, 1, AVL, V5, and V6, are all looking at the lateral portions of the heart. AVR is its own thing. We'll talk about that in another video. It can be useful for some diagnostic purposes, but it is not used as part of our standard STEMI recognition. There's different mnemonics to help remember this. If this is helpful to you, great. I see all leads is a nice little mnemonic that references inferior, septal, anterior, and lateral. If that's helpful, great. I like to think of it in a different view. I like to remember where the leads are pointed. What are they looking at? That helps me think about the anatomical structures of the heart, and I'll kind of show what I mean by that. Our leads provide this overview, all of these different views that we can see. And as we think about each individual lead, I like to think of it as if it were a camera. Where is my camera pointed? And I'll go through each one of these to kind of think about it in that perspective. So the inferior wall, we said before that 2, 3, and AVF are clumped together, and I can remember that all of those are looking at the same area, and AVF is a view from the feet. That's the way I remember it. It's a view from the feet, and I know that 2, 3, and AVF are all looking up from the feet, roughly, giving me this view of the bottom portion or the inferior portion of the heart. 1 and AVL are both leads that come from that view from the left shoulder, so that's a view from the left. And then I just need to remember that V5 and V6 are all the way around the side of the chest, so they're also going to be looking at the lateral portion of the chest. When you look at those together, you're looking at 4 different leads that all look at the lateral portion of the left ventricle, 1 in AVL being a much higher up, V5, V6 being lower, but it's important to remember that these are considered contiguous leads. So even though they aren't next to each other on your printout, they are looking at areas of the heart that are close together, and therefore that can be used for diagnosis. V1 and V2. The way I remember this is V1 and V2 are right in the middle of the chest, right in the center. And when I think of the center of the heart, I think about the septum. So V1 and V2 are looking at the septum. If you see changes in only V1 and V2, it's reasonable to assume that the infarct or the ischemia that you're seeing is isolated to that septal wall. When we go on to V3 and V4, the way I remember this is V3 and V4 are essentially right on the front of my patient's chest, and I'm looking at the front of the patient's heart, that anterior wall of the ventricle. If I see changes there, I'm going to assume that there is an anterior involvement, an anterior portion of the heart involved. It's also important to recognize that V1, V2, V3, and V4, all of them are pretty much looking at that anterior wall. So I said before, if the only place you see changes is V1 and V2, we assume that that is septal. If, on the other hand, you see changes in V1 through V4 across all of those leads, then that's indicative of a large anterior wall MI that probably also involves the septum. When you see that evidence in the septal, the anterior, the lateral leads, that's a clue of an extensive anterior MI or an extensive anterior lateral MI. Either way, this is a big infarct. When you see that combination, you should suspect a left coronary artery lesion or obstruction. That's the one that's referred to as the widowmaker, and it often is going to cause left ventricular failure. It can be a cause of pulmonary edema and CHF, cause cardiogenic shock, and oftentimes when we have a patient in sudden cardiac arrest, it's the result of a blockage of that left coronary artery. This is just another image reinforcing that we can look at the areas on the 12-lead printout, have a clear idea of which part of the heart they represent. And the more you're able to identify and remember that, the quicker and easier your 12-lead localization is going to be. So in an earlier video, I talked about ST depression, and there's a few things that can cause it. It may be a reflection of ischemia. It may be a response to abnormal conduction patterns. I've talked about before that big, ugly, wide, odd-looking QRSs are likely to produce odd-looking STs and T waves. And it also can be a result of reciprocal changes. As I said in an earlier video, reciprocal changes are simply this idea that if I have a camera looking at an infarct, it is going to show me ST elevation. If I have a camera on the opposite side of the heart, it is likely to show me ST depression. That ST depression in this case does not mean that there is ischemia on that side closest to the camera. It simply means that the camera is picking up the evidence of that large infarct on the opposite side of the heart. And since it's on the opposite side of the heart, it's measuring it in the reverse direction, resulting in ST depression. Typically, our inferior leads are going to give us an opposite view to the rest of the leads. And I'll show you a couple examples. In this case, we have a very large, very obvious inferior MI. 2, 3, and AVF all have ST elevation. You don't need reciprocal changes to determine that this is a STEMI. However, as we look at the rest of the ECG here, you notice that across multiple leads, we have obvious and clear ST depression. This is totally expected with a large inferior infarct that we would see ST depression in the others, and it helps to confirm our diagnosis. In this example, we have a large, obvious anterior MI across the V leads, and even in AVL, it's showing up in some lateral views as well. So we have a big MI, and again, you could make your STEMI determination just based on that criteria, and therefore it's not surprising that when we look at our inferior leads, we see ST depression, which is showing us a reverse picture of the exact same thing that you see in your V leads. You do not need to have reciprocal changes in order to make a STEMI determination. You can have an infarct without reciprocal changes, and that's common. But when it's there, it's strong confirming evidence. It helps us to confirm that we were on the right track in our STEMI determination. The two examples I showed were really obvious STEMI. Sometimes it's more subtle, and in those subtle cases, seeing depression in the opposite leads helps us to be more confident in our diagnosis. In the next video, part 4 is going to cover a simple way to approach interpretation. Where do you look first? How do you decide what those findings mean to you?